Then we'll start.
Okay. Okay, sir.
Good evening, everyone. I welcome you to the 7th edition of our TMC Medilogues series. And today we have our very own luminary, Dr. Rathinam, Sivakumar, madam. She is one of the world-renowned authorities on Uveitis. And I would request Dr. Ravi, sir, to introduce madam to the forum. Ravi, sir?
Sure. Actually, it is a great privilege to introduce Dr. Yeah, hello. Am I audible?
Yes, sir.
Yes, sir.
Yeah. So it's actually a great privilege, Venkatesh, that you conferred on me to introduce Madam. Actually, we get inspiration from our seniors. There are a lot of legendary people from Tanjore Medical College, but there are few batches where all of them are legends. So Madam belongs to one such batch. So there Dr. Murali is there, Dr. Niels is there, Dr. Augustus is there. So Dr. Madam is there. So this is one of the probably the best batches from TMC, which has been serving our country, our people for a very long time in multiple specialties. Madam Dr. Rathinam, she has got almost 40 years of experience in Aravind Eye Hospital. So 3 years she was in Tanjore Medical College during MBBS, and then from she completed the course from Madurai, and then she's probably settled in Madurai and joined Aravind Eye Hospital, and she took up the mentorship from Venkateswamy sir, and she trained in Uveitis. So she is actually a world-renowned uvea specialist. So when I went to Aravind to meet ophthalmologist, so she was my guide. So, and her work on particularly the trematode infections, the leptospirosis, the West Nile virus. So some of the infections which were common in and around our own place, like Madurai and Tanjore, which got the proper attention. There was no facility to confirm the diagnosis. There was no proper treatment available. So, due to efforts of Dr. Rathinam and others in Aravind Eye Care, some of the very common diseases got the attention, got how it has to be diagnosed, how it has to be treated. Since then, she has been a pioneer in the field of uveitis. So ocular leptospirosis, trematode eye diseases in children, and ocular West Nile virus infections are three of the most previously unknown infections which they have followed up, and they have given us a proper treatment protocol. So her teaching experience, as I said, is about 40 years, and she is an invited faculty in many of the leading institutions of not only India, like L.V. Prasad Institute. She is a invited faculty. She is also an invited faculty in the University of California, San Francisco. So that's because of the enormous amount of work she has been doing, around 150 plus publications, and she is an author in the textbooks relating to ophthalmology, in particularly the uvea. She is the co-editor of the Will's Eye Manual, uvea Atlas, USA. So, as I said, she has produced so many academic achievements. So many students have come from their institution under her training, and I can boldly say that these people, like Madam, has put India on top of the world in eye care. So I have been, as an orthopedic surgeon, I was fascinated by the work done on cornea, so which is the avascular structure, but still they regenerated. So when I went to Aravind Eye Hospital, Madam was my guide, and I am very happy that Venkatesh gave me the honor to introduce Madam. So thank you, Madam. We are all waiting to hear your lecture.
Thank you, sir. Thank you for Very generous introduction. Actually, I'm just one small nut in Aravind Hospital, sir. Everything goes to Aravind. All credit goes to Aravind Hospital. And today I am extremely happy to interact with you, specifically systemic diseases associated with uveitis. In fact, because it is only 30 to 40 minutes, I have taken only 1/4 of the diseases. And there are so many diseases that is showing clinical signs in the eye. And here you are seeing a beautiful eye, and the cornea is crystal clear. It is crystal clear because there is no vascularization. If by chance, if you see vascularization, we will not be seeing the world as we see. Am I audible, sir?
Yes, ma'am. Yes, ma'am. Please go ahead.
Am I audible?
Yes, ma'am. Yes, ma'am.
Yeah, and slides are clear.
Yes, ma'am.
Yes, sir. So the cornea cannot have blood vessels, and lens cannot have blood vessels, and retina cannot have blood vessels. So there are so many areas in the eye cannot have single blood vessel. So the nature has put all the blood vessels in one compartment, and that compartment we call as uvea. So just to recapitulate, because some of us might have read ophthalmology long back, there are 3 layers in the eye, and first white layer is sclera, and inner layer is retina. The choroid is the middle layer. As you see here, it is full of blood vessels, nothing else. So uvea is comprised of iris, which is seen in front of the eye, then ciliary body, and then the choroid. All the 3 constitute uvea, and it is very important because any infection, just like that, it can go to the uveal vessels and it can manifest there. And now we will see how we are going to see a beautiful lady when the rays are focused on the macula. We see this beautiful lady as beautiful as she is. What happens in uveitis is unfortunately uvea gets thickened because of inflammation. Once it gets thickened, it pours down the inflammatory cells. So inflammatory cells will occupy the anterior segment as well as the posterior segment. So the rays cannot reach there and it gets scattered. Unfortunately, this lady is seen as a small micropsia, small image, and the beautiful lamp she has is glowing so much, she is not even seen. And some of the uveal diseases will give bits and pieces of the image. So uveal tissues can make the patient totally blind, and we have to intervene exactly at the same time, because before inflammation kills the eye, we have to get rid of the disease. So how do we examine the eye? We examine the eye with a standing microscope. So we can literally see living cells in the anterior chamber as well as posterior chamber. That is the privilege we have because of the transparent structures. And posterior segment, how do we see? With the lens, we can focus, and I will show you how we see these eyes. See, when we see with the slit lamp, the normal eye looks like this. When we see with the indirect ophthalmoscope, normal retina look like this. Now we will see how the diseases occur. See, in this case, in contrast to this white, beautiful sclera, it is circumciliary congestion is obvious, and the cornea is muddy, and here is the inflammatory cell deposit you are seeing, and in the next picture, you are also seeing cataract and also inflammatory cell exudates. And this is called hypopyon, and sometimes we will be seeing this iris stuck on the lens, and it is irregular in shape. This is irregular shape, dilated pupil, and here we are not able to dilate because it is stuck with the lens. And how do we see posterior segment findings? Here, beautiful disc, pinkish disc, and beautiful macula. Yeah, in this diseased person, the disc is edematous and macula is edematous. Then in the next picture, here retina is attached and it is pink in color. Here retina is detached and it is white in color. And the other chorioretinal scars because of tuberculosis in a patient, which is extremely destroyed. It is damaged to the extent it is not like normal at all. So this is the way we see the anterior segment. This is the way we see the posterior segment. So what are all the causes of uveitis? It could be non-infectious, it could be infectious, it could be masquerade or metastatic tumors. And I am taking only very important entities because we need at least 3 hours to cover this topic. So to start with, we will start with non-infectious diseases because that is very, very common. Here is a patient who had history of fever on 2018 November, and she lost vision within a week. Just fever and lost vision within a week, and she came to the ophthalmologist, and this was her picture. It is SLE, systemic lupus erythematosus. Unfortunately, her macula has gone ischemic, and she has totally become blind in both eyes. Actually, not all SLE take this path. They will have joint pain, they will have mouth ulcers, they will have other problems. Then during their life, at some point of time, they will develop this ocular complication. They may develop scleritis, episcleritis also. But this very unfortunate lady, newly married, she developed fever and underwent, she had total irreversible loss of vision. And if you see other patients, this is the same lady. This is another 21-year-old college girl, and this is the 40-year-old housewife. If you see the fundus, it is just photographic. If you see this once, you will know that this is SLE retinopathy, nothing else. And all the 3 patients has macular ischemia. And all the 3 cases will never gain vision. And here is the patient with malar rashes, and here is a patient with alopecia also. So SLE is one of the very important systemic disease that can affect that eye can give you some clinical signs. As we always say, eyes are windows to the world. Eyes are windows to see into the eye for the ophthalmologist. And here is another clinical example, juvenile rheumatoid arthritis patient. They also often go blind because regular screening mechanism is not still established in India. In America, once they know JRA, every 3rd month, they have to have ophthalmic examination till they become 5 or 6 years if they are not developing uveitis. If they develop uveitis till the age of 16, they have to have definitely ocular examination. That system is not here. So this girl has lost vision because of juvenile rheumatoid arthritis as well as glaucoma. There is another juvenile rheumatoid arthritis patient, and she has lost both eye at a time. And if you see cornea, it is so muddy, and calcium deposits are seen. And posterior synechiae, iris is attached with the lens. So invariably, this patient will develop glaucoma over a period of time, and cataract also. And if we do cataract surgery before 16 years, the prognosis is very bad. But if we do not do surgery before 6 years, they will go for amblyopia. So this is a very difficult situation. So what we did in this patient, we waited till she became 8 years old, and we have removed just the lens. We did not put IOL also, because IOL give you more complication. And now she has just 1/60 vision, because she presented to the ophthalmologist very late. So her ocular structures were totally damaged. Here is a patient with ankylosing spondylitis. Obviously, you can see the back of the patient and hump of the patient, as well as this patient has acute anterior uveitis with hypopyon. And you can obviously see the iris is totally stuck with the lens. If this pupil is not dilated within an hour or so, this patient will go for uveitis and uveitic glaucoma, and then it is very, very difficult to treat the patient. So once they have synechiae, even if you are not giving steroid, dilating drops should be given. Cyclopentalate or homide eye drops should be given before referring to the ophthalmologist. Or we have to immediately refer the patient to the ophthalmologist. Here is another, this is the way This is the way the iris gets stuck. And iris Bombay, you may remember, you might have studied in ophthalmology. See, the iris is bulged forward, and because of high glaucoma, it is 56, tension was 56. So usually the tension should be 20 millimeter of mercury. Because it is 56, the cornea is decompensating. So immediately this patient should be taken for glaucoma surgery. But in an inflamed eye, we cannot do surgery. So it will be always like neck to neck. Like we have to control inflammation, at the same time we have to control glaucoma also. And next disease is vaginous granulomatosis or polyangiitis, as we now say, microscopic polyangiitis. They also come with the scleritis or episcleritis. If left untreated, this patient will have total loss of sclera. You are seeing now scleral melt, corneal melt. If they are not referred on time, this patient will go, totally they will lose the eye will become phthysical. And these patients, when they present to us first time, we either give cyclophosphamide or we give rituximab, new biologicals, and they get better. Absolutely, they get normal 6/6 vision. It is only the timely treatment that is needed in these collagen vascular disease patients. So here is a patient with scleral melt, and here is a patient with rheumatoid arthritis, and that patient had scleral melt, and this patient has corneal melt. The corneal melt is because of systemic vasculitis. Cornea doesn't get its nutrition, so there is a hole. Sir? There is a hole, and we have not done any surgery at all. We have just given a very aggressive immunosuppressive treatment with steroid, and the hole got closed without any surgical treatment. We cannot do surgery because already the cornea is compromised and it is necrosed because of avascularization, and there is ischemia. So we cannot do surgery because even if we graft, it will fail. So we have to immune suppress the patient immediately so we can heal the patient without even surgery. And there are so many diseases that can come with joint pain and uveitis. As Dr. Ravi mentioned, leptospirosis is one of the common bacterial illness that is seen in our farmers, and it causes fever, joint pain, and it can cause anything. It can cause cardiac failure, liver failure, and it can cause renal failure, and it can kill the person, or it may just cause uveitis alone. So it's a varying presentation of leptospirosis. One important thing is they also have joint pain and many other diseases like lepra, reaction of leprosy, syphilis, chikungunya, West Nile virus, tuberculosis, rifamycin arthralgia. All these things can have uveitis as well as arthralgia. And here is a very interesting patient of Behçet's disease, which is another autoimmune disease that causes mucous membrane ulceration as well as severe hypopia and uveitis. See, the conjunctiva is congested like blood red. And they will, in the fundus examination, they will have occluded vessels, occluded retinal vessels. If they are not treated with the immunosuppressive timely, they go blind. We have so many patients, mouth ulcer patient may not go to the doctor. They take their own medication. Only when the eye gets involved, they come to the ophthalmologist. Because the other systemic findings are also very bizarre findings like arthralgia, knee joint pain, genital ulcer. Once they get the genital ulcer, they will think of sexually associated diseases, so they hesitate to go to the doctor, and they delay so much, the blood vessel get closed. And this is a very interesting patient of sarcoidosis. Sarcoidosis is as common as tuberculosis in India, and this is a pediatric patient with sarcoidosis. And if you see carefully, she has a granulomatous keratic precipitate in both the eyes. Granulomatous uveitis occurs in children in bilaterally. It is either tuberculosis or sarcoidosis. But this patient had joint pain also. Both the knee joints were swollen, and conjunctiva showed conjunctival granulomas and keratic precipitate, and she had granuloma all over her body. And the mother, she was not able to walk because of the joint pain. Mother was carrying this child. But we started immunosuppressive, and now the child has gone to college and she's a grown-up child, and sarcoid is completely under control. It has gone into remission for past 10 years. So this case was outside, it was diagnosed as juvenile rheumatoid arthritis, because it's very, very common to have joint pain and eye problem. But juvenile rheumatoid arthritis will have non-granulomatous keratic precipitates. Here she has granulomatous disease. That is why it is sarcoid. And now we are coming to some of the infectious diseases. Tuberculosis is one of the very, very, very important disease that can show some signs in the eye. And this patient had pulmonary tuberculosis with a cavity, and see here beautiful tuberculoma in the eye, filling up half of the anterior chamber. And she has tuberculoma scleral abscess as well. We actually took specimen from here and we showed the acid fast bacilli, but because eye was very, very, very much affected, she lost the eye. Eye went into phthisis. She should have come in the early stage. And here is one another very, very interesting patient of choroidal tubercular granuloma. But CT chest was normal, CT abdomen was normal. The patient was referred as a case of a tumor in the eye by the general practitioner. ESR was normal, MANTO was negative. But one important thing the patient told is he had back pain, severe back pain, and he had giddiness also. So what we did is we did a radiological analysis, and he had pot spine as well as he had cerebellar tuberculosis. So it was a disseminated tuberculosis, and this patient was given proper anti-tubercular treatment. And see the lesion, such a big tumor has slowly regressed, and it has just left a scar. And this patient had 6/6 vision because he came at right time, and macula was not involved, disc is not involved, so he had good vision. 6/6 normal vision at the end of anti-tubercular treatment. And this is another patient of bilateral granulomatous uveitis. See, when the KPs are seen as a bigger things, it is called granulomatous KPs. And she also had congestion. And fundus of this patient had disc hyperemia, both eyes, and macular fan in the right eye. This we call as neuroretinitis. This patient gave history of fits also. Because she had fits, we did neuroimaging of the brain, and she had a biggest tuberculoma. And we referred to neurologists, and they confirmed with the CSF examination, and then they treated the patient. Patient gained both eye vision completely 6/6, and she became all right. She didn't have epilepsy after that. And this is a very interesting case. This patient also had a granuloma here, a big granuloma, and neuroretinitis like picture here. So usually when such picture is here, our first diagnosis or the first differential diagnosis is tuberculosis. When we asked this patient about cough, he told he was really offended. He told, no, in our generation, nobody had tuberculosis, and I don't have cough, I don't have any lymph nodes. We asked so many history. We told the eye picture looked like tuberculosis. We want to thoroughly examine your system. He was not willing. But what happened is that he's a Keralite. He went to Kerala temple, and after 3 months, whenever he was worshipping like this, he developed abdominal pain. So he went to a gastroenterologist, and they found out tuberculosis. It is a omental tuberculosis with the mesenteric lymphadenitis. Incidentally, he also had ocular tuberculosis. Then after treatment, he became all right. So the granuloma slowly resolved, and he had 6/6 vision. In this case, he had 6/6 vision even in the beginning because macula is not that affected. So he was not cooperative with us to do CT chest and abdomen, but he came with the diagnosed case, and it is a omental tuberculosis. It's a very interesting case. And here is another case, a young male with a scrotal mass, unfortunately diagnosed outside as a cancer, and he's unmarried man. They wanted to surgically remove, but he was not willing. He went home. But soon after 1 month, he lost vision in one eye, and this was a beautiful tuberculoma near the disc. So he came to our hospital, and then he was treated as tuberculosis, and because the disc was totally damaged, this patient did not get back vision. And HIV related infection, there are so many causes that will show clinical signs in the eye. Here is a patient with molluscum contagiosum. This is HIV retinopathy. And this is CMV retinitis. The whole area is retinitis with blood-tinged retinitis. Blood-tinged retinitis is CMV retinitis. When there is no blood, but retinitis is there as big as this, it is acute retinal necrosis of herpetic etiology. All these things can be morphologically diagnosed. We don't even need ocular fluid or any test. And this is toxoplasmic retinitis in a case of HIV patient. This is cryptococcus optic disc edema in a HIV patient. HIV patient, any disease that comes to the system, we can find out in the eye also. And here is a patient with syphilis, and this is beautiful syphilitic retinitis with retinal arteritis. The veins are normal, but arteries are inflamed. So this is one of the classic picture of syphilis, syphilitic retinitis. And recently we found out outbreak of West Nile virus retinitis in 2012. The patient came with retinitis and hemorrhagic patches, which looks like CMV retinitis, but they were not CMV retinitis patients. They were not HIV patients. And we had nearly 260 patients. And see, there is another patient. She presented like this, and the retina healed in the periphery without scarring. And then there is a secondary lesion newly appearing. Here is another patient with West Nile virus, another patient with West Nile virus. We have a apparatus called OCT, ocular tomography. We can just see the retinal thickness. So whenever we get lesions like this, we can see whether the retina is affected or pigment epithelium affected or choroid affected. And here it is, retina is totally inflamed. See here, like your flat ECG, the retina has gone flat and total loss of vision. When retina, this is normal retinal thickness, and this is inflamed retina, this is dead retina. So this case, we did RT-PCR, we did sequencing, we did blast analysis and metagenomics, and we confirmed the case as West Nile virus. We had quite a lot of cases in 2012. And this is dengue foveolitis. Dengue patient, when they give history of defective vision, their macula can show foveolitis. So this patient can have impairment in vision. Total loss of vision may not happen, but impaired vision may be their clinical symptom. And dengue can also cause macular blood vessel leakage, macular blood vessel vasculitis, and because of leakage, the retina is detached like this. But it can be easily cured. We can give steroids. All these viral conditions, except HIV, West Nile virus and dengue virus, other than the treatment that is given by the systemic person, if we give steroid injection behind the eyeball, they get back vision, normal vision. And this is the patient with rickettsiosis. Patient had high fever, headache, and skin rash, and patient has retinitis. And media is very, very clear. If media is clear, the diagnosis is different. If the same patient comes with toxoplasmosis, the media will be totally blurred because of the inflammatory cells. So with additional finding like this, there is no vasculitis in this case, so it is not syphilis. There is no arteritis, and also you have other findings like rashes, so you are able to diagnose and differentiate. The one painful thing is WHO will say there is a dengue outbreak in this year, and there is a West Nile virus outbreak and Ebola virus outbreak. They will be continuously publishing. But unfortunate scenario in PHC is there is one poor doctor sitting and all the patients surrounding him with history of fever. How can he do any research? How can he do any clinical research itself? Leave alone the basic research. Clinical research itself is very, very difficult. He cannot give more than paracetamol in this crowd. So our population is the strength of India, as well as our population is the weakness of India. That is the reason many of us are not able to do clinical research. And this is one of the very interesting case, very interesting case. This patient had sinusitis, and sinusitis was due to Pseudomonas, which we later came to know. So he had severe sinusitis. Somebody told him severe pranayama exercise will make his sinus normal. So he was closing his nostrils, he was closing his mouth. Like Valsalva maneuver, he was doing forcible breathing. Unfortunately, what happened is, you know very well, maxillary sinus is very close to the orbit, and there are apertures to allow the nerves. So this Pseudomonas pus went into the eye, and he developed a Pseudomonas scleral abscess. At this point of time, we took abscess, we did abscess drainage, and we did culture and sensitivity. We came to know it is Pseudomonas, and according to the sensitivity, he was treated, and luckily he got back vision. And this is a very poor man, very poor man. He suffered like anything, and luckily we were able to save his eye. And this is a very interesting disease. Again, one patient came with allergic edema of the lid. And whenever there is allergic edema, we always think of worms also in addition to insect bite. So when we dilated the pupil, we saw biggest worm in the subretinal space. It is an intestinal worm. It has moved through the system and it has gone to the subretinal space. How do we treat it? Long back, people were doing lasers. But once we apply laser in one point, the worm will move to the other point. So it is extremely difficult to treat with laser. It is enough if we give albendazole and steroid. See the scar, the dead worm here. This is the original worm and this is the dead worm. Just 2 weeks of albendazole and steroid made the patient absolutely all right. And we call this disease as diffuse unilateral subacute neuroretinitis, but it's only a worm. And you might have seen quite a lot of larva migrans, visceral larva migrans, and after treatment it leaves. The worm gets killed. And you can have subretinal larva migrans as well. I should not exceed the time. I am going a little fast. And so this is larva migrans under the retina. Once we see this, we give albendazole and steroid. If the macula is not involved, they get back vision. If macula is involved, we cannot do anything. Now we are coming to the third part of the lecture, which is masquerade syndrome. And this patient, 45-year-old man, had pain, photophobia, and sudden loss of vision. And in right eye, only light perception was there. And his mantle was 20 millimeter. And he is a chronic smoker as well. So there were some membranes in the vitreous and also a big subretinal lesion. And our resident diagnosed this case as tuberculosis because tuberculosis can also cause subretinal mass like this. So he wanted to rule out tuberculosis. So he asked for a ultrasound. In ultrasound, you can see a mass like this, a typical mass, which is looking like secondary. And there is a mass here and exudative RD. And it was a bronchogenic carcinoma. And we were not able to save his eye. And he was referred to an oncologist for the further treatment. So this is the metastatic lesion. So this is again a very interesting case. This patient came to us only for glass prescription. Her age was 58 or so. So she needed near glass for a reading glass. And when she came, there was one millimeter of blood in the anterior chamber. It is the only clinical sign. It is extremely rare to have blood in the eye in this age. If it is a 5-year-old child, maybe a trauma, or a cricketer, maybe a trauma. But this lady with no history of injury, this was a very ominous sign. I told we have to do multiple scanning and evaluate you because it is very important. But she was very adamant. She wanted to fight with me. In fact, she told, I have come only for glasses. You say scan. I don't want to spend money for scan. I told there is 1 drop of blood in your eye which may indicate a cancer. Then she agreed. This is something like a tip of an iceberg. We did the scanning, and she had ciliary body tumor, and she had multiple metastases. She had lung metastasis, abdominal metastasis, skull metastasis, and spinal metastasis. Believe me, she died after 15 days before even the treatment was started. And that was metastatic adenocarcinoma with multiple metastases. That 1 millimeter blood was the clue. And this is again an extremely interesting case, a chronic pyuria, and diagnosed as a case of genitourinary tuberculosis by a outside doctor, and she had sensory and motor weakness, diagnosis demyelinating axonal nephropathy or leprosy. She had tropic ulcer foot, suspected as a case of leprosy. Somebody told TB, somebody told Hansen, and nerve biopsy was done in St. John's Medical College to know what it was. But I typically gave the clinical sign. There is a pseudopodial attachment in the lens with the vitreous membrane. It is no other diagnosis other than amyloidosis. So Congo red staining was positive. A just slit lamp examination gave us the diagnosis, and all her foot ulcer, tropic foot drop, everything was due to nerve damage because of her amyloid. This is a case of granulomatous uveitis. And this case was usual differential diagnosis, sarcoid, TB, syphilis, viral. But all these cases, all these causes were ruled out. But this lady gave history of paresthesia and tingling for 3 years. And then we did MRI brain. She was a case of multiple sclerosis. Even multiple sclerosis can cause finding in the eye. Eye is a very, very delicate structure. Any inflammation can just burn it, and the patient may go for irreversible vision loss. So we have to be very, very careful. And whenever there is a ocular symptom, you can immediately refer the patient to the ophthalmologist. If there is no symptom, we need not refer. Thank you. Thank you for your attention.
Thank you, ma'am. Excellent talk that you have covered almost all etiologies as far as uveitis is concerned. So now I open the forum for further questions from the audience. Any comments or questions are welcome.
Yeah, actually, very, very nice. As we expected, so Madam has given us the complete spectrum of all the diseases possible, all the diagnosis with one drop of blood. So how the diagnosis completely changed. So even with symptoms, they have very good, excellent diagnostic modalities like OCT. So I think is as always said, no, after window to the body. And if we don't recognize this window, we become blind. If you want to treat the patient, you have to take the help of the ophthalmologist, because so many things from multiple sclerosis and many of these viral infections which we have never thought can produce dengue. So many of the times orthopedicians we see dengue patients, and very rarely they complain of the vision disturbances, but we have never thought that dengue can have some visual manifestations also. Thank you, madam. Thank you so much.
Ma'am, we have some questions in the chat box.
Thank you very much, Dr. Rathinam. Very exhaustive. Hello, Rathinam.
Hello. Hello.
Yeah,
Thank you.
Very exhaustive presentation, beautiful presentation. And we have 4 blind children with us now, just for your information. One is fully blind. So one got operated recently, 3 months old child recently in your place, just for your information. So blindness is a huge thing. And we have children, 1 month, 2 months old blind with us. And just wanted to let you know, that's all. Yeah.
Yeah, it's very painful to see children blind. It's very, very painful.
Right.
Ma'am, there are a few questions in the chat box. I'll read it out for you. One is about COVID and uveitis.
Yeah, COVID, we had quite a lot of existing uveitis exaggerated, like HLA-P27 uveitis. Almost all my patients came with recurrence during that COVID period. So it had something to do with HLA. And also another syndrome called VKH syndrome. Many of my older patients got new recurrence at that time of COVID. As such, COVID did not produce any retinal or uveal problem, but they had episcleritis. Several patients came with episcleritis. And after COVID, because they were receiving some intraocular fluid, intravenous treatment, some of the patients developed endogenous endophthalmitis. Other than that, episcleritis is the most common finding in COVID.
In prosthetic heart valve infections, endocarditis, one dreaded complication is uveitis, which may end up in panophthalmitis. So what is your experience regarding this, ma'am? Infective endocarditis leading to panophthalmitis and enucleation.
Yeah, panophthalmitis following?
Following infective endocarditis.
Yes, sir, definitely. We have quite a lot of cases, sir. The only problem is because heart is so important than the eye, we advise the doctor to give broad spectrum antibiotic. Sometimes some patient will get better, or after they stabilize the patient, we do vitrectomy and we try to salvage the eye. It is not only panophthalmitis, it can cause endophthalmitis also. When it is endophthalmitis, prognosis is good. We can remove the vitreous and we can inject intravitreally antibiotic and we can save the eye. When it is panophthalmitis, it goes into orbital cellulitis and then cavernous sinus thrombosis. So panophthalmitis, little poor prognosis, sir.
Ma'am, in solid organ transplants, have you come across post-transplant uveitis as a common complication?
No, sir. No, sir. Luckily, by God's grace, after transplant, it is only because of the immunosuppressive they use. Sometimes they get herpes. But because of the transplant, there is no allergy so far we have seen, sir.
Okay.
Madam, actually, I just have a question. Because nowadays they are doing a lot of intravitreal injections. So people are getting every month, once in 3 months. So is that causing any issue for the uvea? Is it
No,
helping
sir.
the uvea or is it?
It is helping the uvea, sir. We also give intravitreal new biologicals for uveitis which are not responding to oral or systemic therapy. And for diabetic retinopathy as well as hypertensive retinopathy, invariably they will be getting treatment every month. But books mention it may cause inflammation, but it is not causing inflammation, sir. And for diabetic patient now, so many new injections have come, and we are able to reduce the blindness in diabetes, which is a very big good news.
Thank you, thank you, thank you.
Thank you, sir. Thank you, sir.
If there are any further comments or questions.
Was the slides visible, sir? Was it clear?
Yes, ma'am. Yes, ma'am. It was very
Yes, ma'am. Crystal clear. You had excellent slides.
Yeah.
Okay, sir.
Very good, Dr. Rathinam.
Thank you, Nilagandan. Thank you so much.
You took us back to third year MBBS to learn the things, and you had shown with all the beautiful slides, and that stole our hearts. Thank you very much.
Thank you.
Fantastic
Thank you so
presentation.
Thank you so much. Thank you.
I was waiting for hearing your lecture for long. Now this forum has created this opportunity. Thank you very much, Venkatesh.
Yes,
thank you very much to the group admins. Fantastic job you have done.
I should thank you all.
It was a great evening. Thank you very much.
Thank you, sir.
Good night. Good night. I mute for others to talk.
Actually, sir, one announcement, if Venkatesh allows. So we are going to conduct next month, September 28th, we are conducting an exclusive CME on burns, both thermal and radiation injured. So it is going to be conducted in Trichy, and Grace Kennett Hospital, which is doing remarkable work on burns in Madurai for almost a century now. So Dr. Augustus, myself, Dr. Sendil Kumar and others at Trichy. So we are trying to organize this conference. So the dates are confirmed, but we will now, the speakers and the other topics we will announce. I request our TMC alumni members to participate and make this a success. Thank you, Venkatesh.
Thank you, sir.
Ravi, you can
Yes.
you can book Zoom during that time.
Yes, sir. Sir, actually, it will be available. It's both online and offline, sir. So
Yeah.
you can register and you can see it online, sir.
Okay. That's a
We will
great
make it
fantastic
hybrid.
idea. Okay. Okay.
Thank you, sir.
Yeah.
Niels never misses any conference. So I
Yeah.
don't know how you find time. As I said, no, this batch, Rathinam madam, yourself, Murali, the Augustus sir. So I think this batch is somehow more special than many batches. I don't know.
we enjoy medical literature.
Ma'am, there is a question in the chat box.
Rathana, I am Kannamai.
Thank you, Kannamai. Thank you for joining.
I was Rathana. நானும் பார்த்துட்டேன் ரொம்ப நல்லா இருந்துச்சு.
Thank
Okay.
you. Thank you so much.
See you.
Thank you. See
நல்லா
you.
இருக்கீங்கல்ல? Okay.
நல்லா இருக்கிறேன்.
Kannamai, good evening.
Ma'am, there's a
நீலகண்டன்,
question in the
நீங்க
chat
பேசுறதையும்
box.
கேட்டுட்டு தான் இருந்தேன். நான் சரி எல்லாரும் முடிக்கட்டும்னு இருந்தேன். நல்லா இருக்கீங்களா நீலகண்டன்?
நல்லா இருக்கேன்.
Okay.
Ma'am,
Okay.
Do we have any question in chat box, sir?
yes, ma'am, there is a question in the chat box. Ocular findings of amyloidosis. How to suspect amyloidosis by ocular findings?
In the lens, there will be pseudopodial attachment of membranes and free floating vitreous membranes will be there. That is very typical picture in amyloidosis, and vitrectomy nowadays is a very common surgery. So we can do vitrectomy and remove the vitreous and stain with Congo red. Immediately you get the diagnosis, sir. So attachment will be very typical pseudopodial attachment of the one side of the membrane, and the other side of the membrane will be floating in the vitreous. Yeah. And the photograph was very typical. The photograph which I showed was very, very typical. I'll try to show it.
Yeah.
One of your last slides, madam.
Last slides, yeah. This is the one. Oh, even this is not the one. This slide. So if you see, there is attachment in the lens, and it will be looking like a pseudopodia. And here also, no other disease causes this. It is pathognomonic picture, and vitreous membranes are here. I have shown a normal fundus and vitreous membranes here. So once you see this attachment as well as vitreous membrane, it is pathognomonic. And in leptospirosis, we will see only the membranes, not the attachment. Leptospirosis will be disc hyperemia, vitreous membranes and retinal vasculitis with hypopia and uveitis. And within a month, we can treat with steroid and get back 6/6. Even if they come with 1/60, it's a very mild immunological disease. So once we give 1 month oral steroid, they get back 6/6 vision. But amyloidosis is a difficult disease. So we refer to systemic people.
Ma'am, this particular patient that you have showed, it looks very young. So what was the type of amyloid that you had?
Actually, this is a very long story, sir. This patient and her brother, both of them had amyloid. Brother died early, and this patient gave birth to twins. She also died in this age. Immediately after our examination, few months she died. And both the twins have amyloidosis. And twins are now in college, and they are waiting for liver transplantation. Every time when they come, this patient name is Geeta. Every time when they come, they used to beg, like, will we be alive? Will we be alive? I am desperate. I will say, wait for the liver transplantation and you will be alive. Like,
okay.
So 4 members in the same family. Sir?
Some form of familial amyloidosis.
Familial
Resolved, ma'am.
amyloid.
What type was it? Any?
Type, we send the patient for workup, but I have forgotten.
Okay, ma'am.
Because this patient came long back, some 20 years back.
Okay.
And can I talk? Every disease has got an answer in regenerative medicine. And can you tell something about stem cell therapy and PRP in uveitis, madam?
Yeah. Actually, as I told you in the first slide, it is made full of vessels, blood vessels. So still the stem cell area has not developed much in the uvea because it is only blood vessels. And all other, even retina, lens, limbus, sclera, everywhere they have found out. Till now, the choroid, nobody has found out stem cell. But retinal pigment epithelium, they have found out. Probably next one to come in line is choroid.
Thank you. Thank you.
Thank you.
Yes, sir. Autoimmune diseases, many of them affect the uvea also.
Yes, sir.
So, as part of the autoimmune disease. And
Yes, sir.
autoimmune diseases, it is now they are trying both hematopoietic stem cells as well as mesenchymal stem cells. So, GVHD, one of the most common complications after post bone marrow transplant, particularly when they are steroid resistant. So, mesenchymal stem cells reduce the the severity of the immune reaction. So, for autoimmune diseases, it is evolving. So, as like Madam said, it will take more time. Actually, for Crohn's disease, they have in AIMS Delhi. So, they have completed phase 2 for the perianal fistula and other complications related to Crohn's disease. But as such, for autoimmune diseases, there are several studies in phase 2 and phase 3. So once they are completed, we will know what cells are the best.
Yes, sir.
Good evening, madam. I'm Murugesh. I'm a microbiology consultant. I'm based
Yes,
in UK. I did my MD microbiology in Chennai. Those days, leptospirosis, they always mention about you regarding your work on the anterior uveitis. Regarding the diagnostic aspects, how did you manage all those PCR work? I read a few of your papers as well, madam. And the diagnostic aspects, it's quite excellent what you've done. And can you please give us some
Yes,
light on all those?
Yes, sir. I was very lucky. I went to Netherlands for a conference. At that time, I came to know, before going to the conference, I was doing Google and I was reading a lot about the Amsterdam city. In Amsterdam city itself, there was a very big tropical institute for infectious diseases, and they were working on leptospirosis. So I asked my hospital to give me 1 month training in that leptospirosis hospital. Before that, I published clinical leptospirosis paper. So they immediately took me for 1 month training. And when we were doing the training, we applied for a Welcome Trust Fund. And with the Welcome Trust Fund, we established microagglutination test, PCR, everything in our hospital itself. So whenever we get leptospira uveitis patient, we were doing free of cost. Arvind was very kind enough to give me that opportunity to do free of cost. And also we were doing whole of Madurai. Whoever sends for systemic leptospirosis also, we were doing free of cost. And that funding was available for 15 years. And after that, the scientist changed her field. So unfortunately, we had to close the lab. But now we have clinically published a lot of papers with statistical analysis, how to diagnose leptospira uveitis. So even with the clinical findings, we can diagnose, like the rheumatological colleagues had a score, no? Like that, I have published one paper, how to give score to the clinical signs and then diagnose leptospiral uveitis. And all the PCR, everything we got from the Welcome Fund, and we were doing that.
Yeah, thank you very much, madam. Yeah, it's quite.
Thank you, Murugesh, for asking that question, because I always feel that all our students, MBBS students, and postgraduates should make one visit to Aravind Eye Hospital, because they have created such a beautiful environment for not only the doctors, it's not only a clinical setup. Their research facility is one of the best in the world. And you can, at a time, you can see minimum of 20 to 30 PhDs working under their lab, their whatever lab they have got. All the equipments are available. And if ever you want to have the latest in the field of medicine, you should visit Aravind and such hospitals. Thank you.
Exactly, sir. The thing is, those days when we did MD in Madras Medical College, we used to go to veterinary college to get all the molecular testing. They had all the sophisticated RAPD, all those molecular investigations, including PCR. And they used to mention about Madam, her work in leptospira. So I had heard about her name. This is the first time I am seeing. So glad to see you in person, madam. Thank you.
Aravind Eye Hospital, on Monday, it will be just like Maha. So better avoid on Monday, go on the other day.
Yes, sir. You are right, sir.
I am Captain Dore Rajan, madam.
Welcome, sir. Welcome.
I am old school, so I may not be up to the mark of stem cell and all. Just I was listening to you. Thank you. It was an excellent lecture. Excellent.
Thank you, sir. Thank you.
So if there are no further questions or comments, can we close this session?
Thank you so much, sir. Thank you for the opportunity.
Thank you, madam.
Thank you.
Thanks for accepting
Thank you.
immediately, madam, and then giving us this wonderful lecture on systemic diseases and uveitis. I hope it was remarkably useful for a lot of our young trainees. A few of them were there in the meeting as well. So I hope it kindles more interest for a lot of people to study ophthalmology. I hope that that part is fulfilled as well. So thank you all for attending, and we'll meet you in another edition of TMC Medilogues in the coming weeks. Thank you.
Yes, sir.
Good night.
Yes.
Take care.